Now we are going into our interview segment, and we're going to be talking about stroke and its rehabilitation. We have two amazing gentlemen in the studio with us to do justice to that topic. And we have Adejugbagbe Muyiwa, he's a physiotherapist. And we have Dami Aino, he is an occupational therapist. Okay, so let's go straight into the topic of the day, stroke and its rehabilitation. But let's start with stroke. Now, what is stroke? Dami.
Stroke is an impairment that is caused by cerebrovascular accident. It's also called cerebrovascular accident. It happens in the brain as in its own is divided into two. So the left hemisphere, right hemisphere. Sometimes you get stroke that affects one or the other. And then because the hemispheres control the counterpart of the brain. So the left side of the hemisphere, left side of the brain controls the right side of the body. So when a person has stroke to the left side of the brain, it affects the right side. And that's the manifestation we see of weakness, falls, and those kind of things.
Now, stroke, as my distant friend has said, is an occlusion. That means there's an obstruction to the flow of blood. You know, if you actually get to have blood not going to this finger, you will start seeing that it starts changing color. And later on, you just see that it becomes necrotic, gangrene, and most of the time, they actually have to amputate that particular side. So the same thing with the brain. The brain actually consumes a lot of blood supply because the blood is what brings oxygen, the nutrients, the nourishment. So whenever there's a blockage and obstruction to the flow of blood, so that's actually where we have that impairment. Now, there's a kind of, the WHO definition of stroke is that the symptoms, are you getting me now, must persist more than 24 hours. Now, there's a reason why we actually get to have that definition. It's because we actually have some other differential diagnoses that mimic stroke, like TIA, we call it transient ischemic attack. So something like this, you just get to have a kind of sudden weakness, and maybe later on, 1 hour or 2 hours later, 2 hours later, you're actually fine. So the person will actually go to church and go and give you a testimony to go to the mosque and say, I am fine on everything, one side of my body is weak. Now, there's a difference between transient ischemic attack and stroke. I get me now. So, and one thing about this, sometimes too, the only symptom that is only, let me say, presentable that we can actually see, I said this person is, the person will just kick the bucket, that's the natural death. So death itself can actually get to be the only symptom that person will actually be manifesting. So look at the definition of stroke now. There is a deficit with blood supply to the brain. The symptoms must persist more than 24 hours. I get me. And sometimes the only symptom that they might actually be presenting or they manifesting, it might actually just be that. So that is stroke. And stroke is so big that they said on yearly basis we have 15 million people suffering from stroke. Look at that now. 15 million. No, that is quite very massive. Yes, 15 million people. Now 15 million, another 15 million, 5 million people are going to actually just, they're going to die from that stroke. Now, another 5 million people are going to be, with permanent disability. And why about 5 million people, we actually have some substantial recovery, whereby they get to be independent. So stroke is actually a very, very big thing. And if you're looking about the second leading cause of death, worldwide, we're talking about this cerebrovascular accident. We don't call it accident. That's what's happening in the brain. So that is stroke for you. What actually causes stroke is that bit of, let me say, barrier to the flow of blood. I get me. So that is like the pathological process that we actually look at. This person is suffering from stroke. Now, we now have risk factors, things that actually places someone at risk, that can make someone to be vulnerable in developing stroke. Now, we have the modifiable and we have the non-modifiable risk factors. Now, the non-modifiable risk factors, you talk about, let me say, the gender. It has been proven that men actually, let me say, they are more vulnerable in developing stroke, but women actually, they are more susceptible from dying from stroke. Are you getting me now? And especially at the younger age, men are more, but after them, say the post-menopausal age, women now tend to actually overtake them. Now we talked about even the race. Yes. It has been shown that African American, with the blacks actually, we are more predisposed and we are vulnerable in developing stroke compared to the Australoids, the Caucasians, and what have you. I get me. So these are risk factors. And again, another thing we also look at, again, part of the that's modifiable risk factors is obesity. Like, someone being bariatric, and everything. we call something hyperlipidemia. That means if the cholesterol level, in the blood is actually very much on the high side.
Yes.
So it can actually predispose someone. Again, the most, let me say, one that is actually the most fatal of everything is hypertension, high blood pressure. High blood pressure can actually, because it's just like, I don't know, have they ever taken your blood pressure before?
Yes,
using a sphygmomanometer whenever they use that cuff?
Yes.
Whenever they're inflating, what do you get to feel like?
It's tightening.
The tightening and a bit of pressure inside. So just imagine the pressure in the blood vessels in the brain.
Wow.
That's what the way we have the systolic and we have the diastolic. So we said the normal one should be, 120/80. So imagine someone having 194. Now 194 millimeter mercury in the blood vessel, that is the artery. So you can just imagine the pressure. Like pressure is defined as force over area.
Yes.
So that means what the force at that particular area is actually very, very huge.
94.
So that's what can result to the hemorrhagic stroke. So just what burst, pa. We call that one the intracerebral hemorrhagic stroke. So these are some things that diabetes mellitus, are you getting me now?
Yes.
People that actually get to smoke, heavy smokers. People that actually drug abuse can also get to predispose someone to having all these things. Having a kind of maybe heart disease, like a kind of coronary heart disease too, can also predispose one.
Okay.
So a lot of all these factors actually play together. And one thing, because if you stop the after lack of physical activity, a sedentary lifestyle, and you're neither, most of the time, just you don't exercise. These are the things that really can predispose one in developing stroke.
So,
Dami, do you have more to say on that?
I think you covered everything. You covered
Okay, in light of that, you mentioned smoking being one of the causes, right? Heavy smoking. Now, I have this friend who smokes every hour of the day. He smokes in the morning, afternoon, and night. And sometimes I get worried. I'm like, isn't he getting too much? So at some point, there was this day he told me that he sat in class and after the lecture, he couldn't move. And I was worried because I think he had malaria before that. And he said he didn't know what was wrong. He was scared and freaking out, but he could not move a muscle. And so I got worried. I told him, and when he came back, when he was able to finally move, the first thing he did was light a cigarette.
To ease all the
Yes.
Wow.
And I mentioned something about the TIA, that is the transient ischemic attack. Now, we have different types of, in terms of, let me say, the duration of the stroke. We have the transient ischemic attack. We have RIND. RIND is reversible ischemic neurological deficit. Now, I repeat that. No, reversible. Ischemic neurological deficit. That means it is reversible. So, but that one actually takes like some weeks. But the one of the TIA, the transient ischemic attack, that within 1 hour, it can just happen for like about 10 minutes. So maybe actually what he suffered back then was just, and that one is an indicator that, hey, guy, be careful.
Yes.
Because futuristically speaking, most likely he is going to come down with stroke if care is not taken. So that your friend, you have to just educate the person and say, oh, take it easy. Apart from just, say, the lungs actually and everything getting, now be wary of stroke because that one is
Okay, so the question I was trying to bring in there is, that is a smoker, right? Yes. And you've mentioned smoking. So aside from that, what kind of individuals are prone to coming down with stroke?
I think it's a combination of everything he has talked about, and the fact that if a person can be obese and be going through a lot of be very physical with work every time and think that they are doing exercises, but then they have like cholesterol, hypercholesterol, like you talked about, and so there are many other things. There are people that are very skinny that don't want to look like they'll be very sick at all, but then they have like their lungs are blocked, their arteries are blocked. So you have to continue to do a checkup as often as possible. Anybody can have a stroke. Anybody can have a stroke. There's no, oh, this person comes from this area, so he has to have. Anybody can have a stroke.
I know you mentioned that. I know you mentioned a baby can have a stroke.
Yes, a baby can have a stroke, and it's. So a stroke, like he has explained, is an occlusion of blood cells.
Yes.
So an occlusion of blood cells at any age can happen and can lead to deficits in function.
Let me just chip in this.
Okay.
It's like when I was having my clinical examination at College of Medicine, Louth, and there was this question, there was a baby that was presented, oh, can you, like the diagnosis of this baby? Because I was like, come on, this is like, no, it's not possible. I said cerebral palsy. Okay. Cerebral palsy is not, let us go into that, one's another topic for another day. So I said, no, look at this baby very well. This is one side that is affected. I said, no, so I'm sure this is a pediatric patient, so most likely it's going to be, cerebral palsy. But later I get to find out from the issue that this person is sickle cell. You know, it's just like we talked about occlusion. You know, for sickle cell patients, we get to see that the shape of the red blood cell is actually sickle-like.
Yes.
Are you getting me now? So sometimes as the blood is passing, they can actually get, because it's not the normal, you know, concave and round one that will flow easily. So because of that abnormal, you know, shape, so it can actually get this occlude, you know, or let me say block that particular blood vessel. So most of them you actually see, you know, we call it infantile stroke. That's what young ones actually even coming down with stroke. And now we say that maybe stroke is for the elderly, but I tell you, at least in the hospital rehabilitation, we having 30, you know, that 30-year-old person, individual coming down with stroke. Stress too. At least we get to know the peculiarity of where we are living in this part of the country. You know, when we don't sleep adequately, we don't eat good food, we don't exercise. Someone told me that, Shebi, what do you mean by this exercise? But I'm always trekking. You know, because maybe as a result of traffic and
moving around.
There's a difference between stress, I get me now, and you exercising. We need to get that difference. Obviously, but I'm always jumping from one okada. No.
So that's not a form of exercise.
It's not a form of exercise.
Wow.
I get me now. We must actually get to know the difference between exercises, I get me now, and just we stressing ourselves. Now, the kind of traffic that is building up in front, I decided to trek for 2 hours. You didn't plan for it. It's something that is because of the circumstances. That's
stress.
So a lot of things. So like what I told about the non-modifiable fact that you cannot do anything about it. Familiar history. If you ask, oh, my grandfather, one uncle had stroke. Now that is an indicator, it's a precursor that you have to be very, very careful.
Yeah, that means the
so are you trying? Yeah, exactly. So are you trying to say that it tends to be genetic?
You know, in that particular, let's say, whereby it can be, and that's what we're talking about. That is the hypertension. That is the high blood pressure. Okay. So it runs in the family. Like you take someone like this, 200/130. I say, wow. So my sister, my brother, that's the way my dad do. Even my uncle, this. So that's one can actually have a kind of, you know, predisposition to actually having stroke.
And if you have predisposition to it, doesn't mean that you would have it. You can have lifestyle changes that would effectively. So if you have, if somebody's grandparent had a stroke and you choose not to overfeed yourself with cholesterol, you choose not to smoke, you choose to exercise, which exercise is determined as raising your blood pressure, not your blood pressure, your heart rate. Right? Raising your heart rate purposefully. Not because you are stressful, not because somebody's breaking into your house. So by raising your blood pressure, raising your heart rate to affect blood flow and to affect circulation of nutrients in your body. So those are the things that you can do even though you are genetically disposed.
All right.
So, Dami, can stroke limit a person for the rest of their lives? I think you said it can. And also, what is the rehabilitation process for stroke?
So stroke can be debilitating, can limit the person for the rest of their life. And there are some people that fully recover. So like Muyiwa talked about, you can divide them into three. People that people that die, people that partially recover, and people that fully
recover.
When you say fully recover, so you have to is subjective. So in a society where everybody expects a person of a certain age to act a certain way, then if they are limited in their function or maybe they had a stroke and they cannot think about mathematical equations properly, did they get their function back? So those are the kind of questions that makes it very subjective. So when you think about it in that sense, somebody that was an accountant that was going to work every day and had a stroke, but now is struggling with mathematics, there are ways that rehabilitation can help the person get back as much function as possible without him being, he can't perform his function anymore and putting him away. You can always, there's ergonomics that can be where the job is fit to the person based on his limitations and different things. So even though there are limitations, there are ways that rehabilitation can help with maximizing function.
Okay, so what is the rehabilitation process like?
Okay, at least I think we had one interview here one time, and we talked about just rehabilitation as a whole. Rehabilitation is just English word, like like you repeated something, habilitation. That means, what you used to do, your abilities and all. It's just like re-education. If it's actually a newborn baby, like that, maybe with cerebral palsy, we call it habilitation. Are you getting me now? So it's something that you actually have it in you. You have been doing it before. But as a result of this accident, which you refer to as stroke, I get me, you lost that particular ability. Now, we're so much in this part of the world whereby we just focus on stabilizing the vitals. What are the vitals, the blood pressure? We try to calm the person. Now, okay, we get to see that everything is fine, and we discharge the person off. This, I've had a patient came to meet us one time. I know, like, I said, "Ma, when did you have this thing?" During the course of clicking. And say, "No, she had it 8 years ago." I said, "Okay." I said, after they've stabilized my vitals, the next day they said, "Well, I should go home. That is just like malaria, that it will go and disappear." Wow. I said, like, seriously?
Wow.
So we actually have a lot of education as regards, rehabilitation. Now, rehabilitation actually is not just, it involves the neurologist, it involves the physiotherapist, it involves the occupational therapist, the speech therapist. I love what you actually did there. It's actually captured everything. We have the prosthetist and the orthotist, so everybody actually coming together. So that is where the part of interdisciplinary and multidisciplinary approach when it comes to rehabilitation. Now, it's just what, bringing about and making them independent as much as possible. Because we don't want someone that will just be dependent on one distance, because everybody actually live their own life.
Exactly.
So it's just to, the goal and the objective of rehabilitation is what? Get this person back to his or her pre-injury status, make the person want to be physically fit and independence. That is very, very sacrosanct. And that is actually, let me say, the foundational principle on which rehabilitation is actually built. So every physiotherapist, every occupational therapist, this is actually what they work, hand in hand in synergy to bring about. That is rehabilitation.
Thank you so much.
Thank you so much.
To enjoy more interesting episodes of Tea or Coffee, then like and subscribe.